بسم الله والصلاة والسلام على رسول الله. Assalamu alaikum wa rahmatullahi wa barakatuh jami'an. Welcome everyone to an exciting webinar about the history and evolution of the endoscopic frontal recess approach by the pioneers Dr. Frederick Kuhn and Dr. Amin Javer, who I'm honored to host in this webinar. I'm Saad Alsaleh, Associate Professor of Rhinology and Skull-Base Surgery at the King Saud University, and the chairman of the ENT department as well. And I'm honored to have Dr. Frederick Kuhn with us, who will be giving a keynote lecture about his views and history of frontal sinus surgery. He's the Emeritus Professor of Surgery and Otolaryngology at the Medical College of Georgia. He started a Rhinology Fellowship in '92 and have trained over or around 26 fellows ever since. He founded the Georgia and Nasal Sinus Institute in 1999. He's the past president of the American Rhinology Society, part of the editorial board of the American Journal of Rhinology as well. He's published 73 scientific articles and 10 book chapters, where we actually still use to date multiple things about frontal sinus surgery as well as allergic fungal sinusitis. Directed over 90 courses in sinus surgery worldwide. And he's the twice recipient of the Morris Cottle Award for Research and Excellence in Rhinology. And he's designed and developed 36 surgical instruments, which we actually still use today, especially in the frontal sinus surgery. And I'm also honored to host my personal mentor and dear friend, Dr. Amin Javer, who's the clinical professor at the University of British Columbia, director of St. Paul's Sinus Center, research co-director at UBC ENT. He started the Sinus Fellowship training program at St. Paul's Sinus Center in 2001, has trained 20 fellows, which I'm honored to be part of. Over 90 research publications and 10 book chapters. And amazingly, he's fluent in 5 languages as well. And I would like to thank you both for your contribution. We're truly standing on the shoulders of giants, and we can definitely see further at this point. I'd like to welcome to the podium Dr. Frederick Kuhn, and you can share your screen right now. The podium is yours.
Thank you, Dr. Alsaleh. Welcome, everyone. It's an honor and a privilege to be able to join such an august group and to share some of the things out of my past experience. So you'll see the title is Frontal Sinus Embryology and Anatomy, which is what I always enjoy talking about. However, my dear friends have asked me to digress from that slightly and share some things about the history and development that I've gone through in coming up with the endoscopic frontal, the refinements, the endoscopic frontal recess approach. I need to figure out, Saad, how to move the image. Oh, I know, I can minimize it. There we go. Back when I was trained in the early 1970s, the only frontal sinus procedures that were available to us at the time were the tree fine and the frontal sinus obliteration. The Lynch procedure had been pretty much abandoned because of its destructive nature and the fact that it commonly scarred the frontal sinus drainage pathway. Intranasal ethmoidectomy was practiced by a few people, but deemed to be a fairly dangerous operation, and it was not taught, at least in our residency program, but I think in most. That is, not taught in most residency programs. So, unbeknownst to me at the time, and obviously to my professors, 20 years before, Professor Walter Messerklinger had begun studying the mucociliary clearance patterns in fresh cadavers using India ink powder in open dissected sinuses and high-speed photography that could be later slowed down to look like slow motion photography. He also developed some endoscopic techniques which were eventually brought to the United States by Professor Heinz Stomberger in 1985. as David Kennedy had invited him to come over to teach a course. And David Kennedy adopted the term functional endoscopic sinus surgery, which he applied to it. But still, the frontal sinus was somewhat of a problem. So between 1985 and the year 2000, the cells that potentially obstructed the frontal sinus were eventually described in modern terms, and the endoscopic techniques of frontal sinusotomy were refined. In addition to this, in the late 90s and late 80s and early 90s, image-guided surgery came onto the fore, and Dr. Zenreich at Hopkins was the person who was exposing us to this, and it was done by a company called ISG in Canada. Eventually, visualization technologies in the United States followed, and that was reported on by Marvin Freed. And it became an important adjunct to our surgeries, and now I will be bold enough to suggest that it is the standard of care. It's taken years to get to that point, but I believe that to be the case now. So in my personal history, in 1985, I had not been to the Academy meeting for 2 or 3 years, and I decided it was time to go. So when I walked in the door of the exhibit hall, where I always went first, I immediately went back to the Karl Storz booth to see what they had, and asked my favorite question of one of the representatives, which is, what do you have that's new? He took me around the corner and showed me a tall, slender European physician looking up the nose of a very attractive redhead with a telescope and projecting the image on the screen. And I thought, oh my heavens, this is new. So that's when I had the opportunity to sort of meet Heinz Stomberger, and saw David Kennedy from a distance when he walked up. Realized at that point that there was an instruction course they were off to that was too late to sign up for. So I had the opportunity to stay there in the exhibit booth and study all of the videos that Heinz Stomberger had brought with him from Graz, Austria, 3 to 4 times over the period of the next 2 days. I ended up walking out of that Academy meeting with $15,000 worth of instruments and telescopes, went home, did my first case. I was comfortable from the videos getting back to the face of the sphenoid, but decided to stop there because I was unsure about it. Took a course the following December at Yale, and again was fortunate in that Dr. Kennedy and Stomberger and Zenreich gave superb lectures, and in the laboratory, Heinz Stomberger came over and sat down with me and showed me a few things, particularly how to safely get into the sphenoid. So the people that I've already mentioned that I met at that Yale course face-to-face were Dr. Kennedy, Dr. Stomberger, and Dr. Zenreich. And all credit to them that's due, probably the most important person for my development at that point was Ellen McDonald from Karl Storz. She was my contact person with the instrument company. And so over the course of the next year, the next few months, I came to the realization that the light post on the telescope was in the way of me doing my dissections. So I called her and asked her if they could make a telescope with a reverse light post so that I could get the light cord out of my way coming out the bottom of the telescope and move it to the top. She says, well, interesting that you should ask, because we have that in our inventory, but nobody asked for it. So I ordered some, she sent them to me. In June of '86, I took my second course at Johns Hopkins. Did a decent enough job that they were desperate for people to help them in the laboratory in their courses, and they invited me to come down to the University of Florida that fall and help them teach a course there. I went back to Johns Hopkins in June of '87 and took my third course, which was at Johns Hopkins. and by this time had developed an interest in the Agger Nasi cell. So I convinced David Kennedy that it would be a really good idea for him to come to Oklahoma City to put on a course, which we did in late '87. He was gracious enough to do that. And following that, I took my fourth course, this time in Dallas, where the Wiegand technique was taught. So accumulating all this information and having some leftover split cadaver heads following this course in '87, I asked one of my favorite radiologists if she would do some direct sagittal CT scanning of that specimen. Because if we go back to the first course at Yale, when Dr. Zenreich was teaching us the radiologic anatomy of the sinuses, to make it possible for us to go home and really evaluate the CT scans of our own patients. And I have to say that at that point in time in '85, CT scans were not widely available or widely used. And I need to go back a slide. Nope. Here we go. So when Dr. Zenreich, pardon me, fellows, there's something wrong with what's happening with the slides. Just a minute. Dr. Alsaleh, I have to figure out how.
I think if you can just press escape, probably. Yeah, and there's just that button that's highlighted.
Yeah, now, the other thing.
Yeah.
Okay, good, thank you. It just doesn't seem like the slide is filling the screen now. But at any rate, if we go back to thinking about that first course, when Dr. Zenreich was describing the radiologic anatomy, he showed sagittal reconstructions, but the problem was the cuts that were used to, the axial cuts that were used to acquire the data were so far apart that the reconstructions were very stair-steppish. So we were limited at that point to taking direct axial CTs and direct coronal CTs. But he showed us detailed information on the sagittal CT. As rough as it was very important to us. And talking about an anatomical detail that I was unfamiliar with, which was the sinus lateralis. So again, I need to reverse. So just keep that thought in mind, and I'll tell you what my solution became with that. So at any rate, after Dr. Zenreich and Kennedy came down to Oklahoma City, the next thought that occurred to me was that people in general did not have enough access to dissection courses, and I did not really want to try to compete with Dr. Kennedy by creating a parallel course to his. So what I decided I could do would be to create a quote unquote advanced course, which was primarily a dissection course. So we did the first one of those in 1988, and that's when I discovered how to find the posterior wall of the Agger Nasi cell and make it simpler to be able to dissect it out of the frontal recess. So that was the first really light bulb that went off regarding frontal recess dissection. Or maybe second, after the use of a reverse light post 70-degree telescope in the frontal recess. Then in 1989, I was fortunate to go to the 8th ISIAN in Baltimore and discuss the recurrent causes of recurrence after functional endoscopic sinus surgery, and I was able to meet Professor Wiegand and began designing the first set of instruments, the giraffes, the frontal giraffes, the seeker, and the frontal sinus curettes when Dr. Bill Bolger came to spend 3 months with me. In 1990, began writing the Agger Nasi cell and frontal recess obstruction. Presented the paper at the Pittsburgh International Conference, met Dr. Gary Wolf from Graz and Wolfgang Graf from Germany. In 91, gave up my private practice and moved to the Medical College of Georgia as an associate professor, and was invited to come to Graz, Austria to help Heinz Stomberger with his course, and was presented with my first set of instruments. The Agger Nasi cell paper was published. The following year, I had the great good fortune of having Dr. Carlos Cuilty-Siller come spend 2 years with me doing laboratory research on capsaicin's response, the nose's response to capsaicin, and doing a significant amount of work on the neural connections between the fifth nerve nucleus, the nasal cavity, and the face. First identified cells that we came to call frontal cells and how they were playing a part in frontal recess obstruction. And then Dr. Cuilty sent 2 of his colleagues, Dr. Rodriguez and Dr. Gonzalez, to follow him in that research role. Michael Siller's team in 93, and during that time, we began trying to simplify the way people got to the maxillary sinus ostium and describe it, because we were seeing so many patients with surgery who had persistent disease, and instead of the maxillary sinus ostium being opened, there was an opening punched through the posterior fontanelle. We spent more time understanding and describing the supraorbital ethmoid cell, working on a middle meatal spacer, and Michael Siller's work on determining the amount of corneal radiation exposure with thin cut CTs, to try to dispel the idea that if we did thin cut CTs, we would be producing cataracts in patients. Once that hill was climbed, we were able to do decent sagittal reconstructions. And at the same time, the helical CT came on the market, which had even less corneal radiation exposure, and suddenly sagittal reconstructions were available. Dr. Sillers was followed by Dr. Arthur Wood. Our first foray into understanding allergic fungal sinusitis was going on at this time. And we did our first Lothrop procedure with punches, trying to figure out how it could be done without using a drill. In 95, I gave up that position and moved to Savannah, to the Georgia Ear Institute, to set up a sinus center for them, and began using image guidance in sinus surgery that Dr. Zinreich had been telling us about for years, but that I had not had available. Then in 1996, when Dr. Citardi joined me, we created and did the first frontal sinus rescue procedure. And as you'll find out later, I was anxious to find some way to solve the problem for people who had their middle turbinate removed, the frontal sinus guard over, and I did not really want to either obliterate them or to drill in their nose. We also published some things on postoperative care. And then from 97 to 98, I had Dr. Winston Vaughn, followed closely by Dr. Amin Javer as fellows. We worked on flexible frontal sinus stents and did more work on middle meatal spacers, and finally left there and established the Georgia Nasal and Sinus Institute in 1999. From 2000 to 2017, when I retired, we spent a great deal of time working on frontal sinus unobliteration, trying to remove frontal sinus osteomas without damaging the frontal sinus drainage pathway. Dr. Mark Dubin challenged me when he came, saying, how do you know that 6 weeks of medical therapy with antibiotics are better than 3? So he proved that point, and that's been one of my mantras all along, is that we have to treat people maximally with medication before we resort to surgery. We started doing tissue eosinophil counts, paying attention to coagulase negative staph as a cause of sinusitis instead of just an everyday organism in the nose. And categorizing eosinophilic chronic rhinosinusitis to include not only allergic fungal sinusitis, but sinusitis caused by superantigen or the eosinophilic response caused by superantigen, aspirin-sensitive asthma, and a host of gram-negative organisms, including Pseudomonas. Then Dr. Chan published a paper on our long-term frontal sinus patency during that period of time, and Dr. Saad has already mentioned the fellows that we've had the privilege of training. So now, given the history and a rapid trip through development, I'd really like to get down to the part that I like the most, and that's dealing with the anatomy. And we'll go back, all of you know the term frontal recess. What was interesting to me when Dr. Bolger was with me, that we went back and found that it was Killian in about 1898 that first coined that term. It was its understanding was greatly enhanced by J. Parsons Schaefer, who was the Daniel Ball Professor of Anatomy at Thomas Jefferson University in Philadelphia, in his papers and book of 1916 and 1920, followed by Hans von Allier in his papers from 1934 through 1948 on the frontal sinus as it relates to endonasal surgery. So to try to make this concept of frontal recess, which many of us have attempted to define, but have realized that it is ill-defined, difficult to define, and there are not normally great anatomic landmarks to point to say, yes, that's the frontal recess. So what we decided to do is to try to imagine this as a funnel-shaped space, an inverted funnel, with its smaller end at the frontal sinus and its larger end in the anterior ethmoid. So it basically is the space through which the frontal sinus drains into the anterior ethmoid. And as we've already mentioned, it has no clearly defined openings, either superiorly or inferiorly. So as you will see sometime as we move on, we have attempted to refine it somewhat, but it won't show up yet in the slides. So this is a stylistic drawing that we did back in the late 90s. And you can see we were still calling this the infernal frontal ostium at that point, but again, it's just this opening wherever you finally define the opening to be. The frontal recess parallels the skull base, generally back to the ethmoid bulla lamella. It parallels down the face of the frontal process of the maxilla. We used to call this the anterior wall of the Agger cell, and it is very commonly pneumatized by other, what we call cellular-like structures. In this particular case, a stylized Agger cell. So where does this develop? How does it develop? How do the anterior ethmoid sinuses develop? Because as surgeons, we're particularly interested in anatomy, but if we start trying to understand complex anatomy, we need to go back to our freshman year in medical school, to our embryology course, and revive that and look again at embryology. Now, over the last 35 or 40 years, most of us have been told that the first embryologic ethmoturbinal becomes the uncinate process, and the second one, the middle turbinate. But if you start thinking about the excrescences on the lateral embryologic and neonatal lateral nasal wall, you realize that the uncinnate's the first one, the ethmoid bulla is the second one, and behind that is the middle turbinate. So where does ethmoid bulla fit in the first one? Well, then if you say, okay, the first one's the uncinate, the second one's the bulla, and the third one's the middle turbinate, if you stop and look at the embryologic wall, which we will do in just a moment, you realize that the middle turbinate has to grow forward and cover the other two. So once again, if we remember to go back and carefully read the earlier literature, what we discover is that both Schaefer in 1916 and 1920 and Vanellier in all of their papers assigned the first embryologic ethmoturbinal to the middle turbinate, the second one to the superior turbinate, and the third one to the supreme turbinate. So you say, well, what about the uncinate and the ethmoid bulla? Well, what they discovered is that underneath the middle turbinate, within the middle meatus, there are two secondary middle meatal turbinals that develop into the uncinate process and the ethmoid bulla. So if we look at the upper right part of the slide, you can see that we have a maxilloturbinal that develops into the inferior turbinate as the lower one. And then above that, we have ethmoturbinal 1, 2, 3, 4, 5, 6, etc. And then you can see if this was uncinate and this was ethmoid bulla, how far the third embryologic ethmoturbinal would have to migrate forward to cover all of these. So that's why Schaefer's pictures and description make far more sense. Now, each one of these ethmoturbinals and the two secondary ones that occur under the middle turbinate have an upper part of the hockey stick, if you will, that's called the pars ascendens, or the ascending part, and a descending part, or pars descendens, here. So keep that hockey stick configuration in mind and the division between the two as we go to the next few slides. So here we have the middle meatus opened. This part of the middle turbinate has been removed. And you see the first middle meatal turbinal, which will become the uncinate process, and the second middle meatal turbinal, which will become the bulla lamella and ethmoid bulla once pneumatized. In between, we have the hiatus semilunaris opening into the ethmoid infundibulum. Now, if you'll notice, there seems to be a division somewhere between the upper pars ascendens and the lower pars descendens. Heinz Stomberger, as long as I knew him, maintained that the upper part of the uncinate developed into the Agger Nasi, and the lower part developed into the uncinate process as we know it. So if we look at these upper parts, Schaefer talked about frontal pits and furrows separating them, and that the pits developed into various air cells, one of them pneumatizing up into the frontal bone and becoming the frontal, what we call the frontal sinus, and others becoming other anterior ethmoid cells. But imagine somewhere in here, there's a theoretic division between the ascending part and the descending part that we haven't really described yet. So now let's talk about the Agger Nasi cell, which we first encountered in about 86 and described through 89. This is the first cadaver I was able to get my hands on after that Oklahoma City course in 1987. I had some extras left over from that course. And this is, I had 3 of them, had them all 3 scanned, and this is the one that had an Agger Nasi cell in it. So we decided to dissect this a piece at a time and compare it with the radiographs. And remember, these are direct sagittal CT scans at that time, which we did not have available in the live human. So here you can see, after we've lifted up the septum and resected this much of the middle turbinate, that we can see the uncinate behind the middle turbinate or lateral to it and attached to the posterior part of the Agger Nasi cell. This is a flap that has been opened and laid forward so we can see the interior of the Agger Nasi cell. On the accompanying CT scan, you can see how it pneumatizes up into the frontal recess, very nearly obstructing the frontal sinus at that point. So here's a little bit deeper dissection, primarily just lifting up the middle turbinate so you can see the relationships. This is what we would normally call the uncinate process, the hiatus semilunaris and the ethmoid infundibulum, the ethmoid bulla lamella also attaching to skull base and being pneumatized down here, forming a small bulla. And lo and behold, behind this is the structure Jim Zinreich taught us in December of 1985 called the sinus lateralis. Its name has subsequently been changed to the retrobulbar recess, but you can see a perfect sagittal CT scan representing that area. So it's this type of sagittal dissection that I fully believe everyone needs to be able to do in a dissection laboratory to fully understand the anatomy that they're dealing with. Here we are a bit deeper. You can see the size of this Agger Nasi cell pneumatizing up into the frontal recess in front of the ethmoid bulla. This is the anterior ethmoid artery, and this is the frontal sinus above it. Now, I want to call your attention to one particular item in this picture that we're going to see in a few minutes, demonstrated in a different way. This hair cell, as we have called it, has an opening right here that empties into this part of the infundibulum. So this is where we would normally say the ethmoid infundibulum went, and it came back down this direction to empty, and behind the uncinate process here in the anterior fontanelle, we would find the maxillary sinus ostium. But notice in this particular anatomical picture how the drainage pathway out of this cell comes right into this part of the infundibulum and goes right across the maxillary sinus ostium on its way out back here. So we've talked a lot about cells. We have all been ingrained with the idea that the ethmoid sinus is made up of multiple cells. But I want to make a suggestion to you. I'm not asking you to change your nomenclature. I'm asking you to expand your imagination and think about the fact that what we have called cells are truly spaces enclosed by bone. And I have to tell you right up front that I owe this perspective entirely to Dr. S. James Zinreich, former professor of radiology at Johns Hopkins, chief of neuroradiology. Each one of these spaces has its own drainage pathway. So one of the things that we need to change in our conception that I believe will make it more helpful for us to understand how any given patient's pathology comes about and can be solved. So if we can speak about cells, but if we start thinking about cells as air spaces with a drainage pathway connected to another airspace, then we can begin imagining how we can improve the drainage out of those spaces. I'd also like for you to imagine that the uncinate process may have two parts. The part that derives from the pars ascendens, which Dr. Zinreich has coined the term ethmoidal uncinate process for the upper half of the uncinate, and the lower half, which assumes more the shape of a turbinal or more the shape of the embryologic turbinal from which it came, he's termed the turbinal uncinate process. The third concept I'd like for you to consider is that the infundibulum that you have imagined in the past as a cleft, a simple sickle-shaped cleft, actually has three parts to it. The three parts are named the ethmoidal infundibulum, which is enclosed by the upper part of which we've considered the uncinate process. the turbinal infundibulum enclosed by the lower part of what we have called the uncinate process, and it's in contact with the maxillary sinus ostium. And yet there is an intervening part that we haven't ever considered as part of the infundibulum, and that would be the infundibular space enclosed by the bony three-dimensional outline of the ethmoidal uncinate process. I'll let you think about that for a little bit and then try to give you a visual so that it will be easier to conceive of. And then the fourth concept is that the frontal sinus and the frontal recess are one single space. I think probably many of you would agree with the idea that the frontal sinus develops from the frontal recess. But when I think about the two prior to 3 years ago, I thought of them as two separate spaces. So why are we beginning to think that they're a united single space, even if we give different parts of them different names? And that is because radiologically, there is no definable point or plane of separation between the frontal sinus and the frontal recess. Now I'll have to let you and ask you to take that on faith for the time being. But as we go back to J. Parsons Schaefer's drawing, if you notice this red line across here, it begins at the lower, and incidentally, what we have called the face of the Agger Nasi cell is really and truly the frontal process of the maxilla, its posterior face, which is basically an inverted isosceles triangle. Again, I'm going to insert here that all of this new information I'm giving you is information that has been gleaned from the brain of S. James Zinreich over the last 5 years. It originated there, and I've been fortunate enough to be exposed to it. So if indeed the upper part of the uncinate process, as Heinz Stomberger has tried to explain to us for decades, forms into the Agger Nasi cell, well, somehow this bone has to come this direction and attach to something because it's not attached to it now. So, and yet we still have this piece of uncinate that comes up the back of the Agger Nasi cell and attaches to skull base. So this, if you can allow this for a while, I'll show you in a minute how it can be. The lower part of the uncinate is the turbinal uncinate process. The upper part, a new term for it, is the ethmoidal uncinate process, and it becomes a three-dimensional space-enveloping bone with an outlet right down here. So here we have what Dr. Zinreich has been working on for over 5 years. This is three-dimensional CT scanning using stereotactic imaging. All of you probably have had the opportunity to take plain x-rays that were taken a few degrees apart, hold them up to a view box and cross your eyes to try to look at them and merge them and make them look three-dimensional. That's the general concept of what's going on here. And so by doing that radiologically, he is able to create a three-dimensional picture of the anatomy. So here in this first image, there are 3 planes shown, and I've separated them with a dashed line to make it easier for you to conceive. I did not do that on all of these images just because it's time consuming and not important to what I want to say. But above we have an axial plane, we have a posterior coronal plane, and here we're looking at the sagittal plane. So he has removed the middle turbinate so that we can look into this picture slightly from behind and see something comparable to the anatomical dissection pictures I showed you earlier. Here is the back part of the uncinate attached to the medial maxillary sinus wall. Here is the posterior part of the infundibulum. This is the face of the ethmoid bulla. This is the medial surface of the bulla. And this blue line or blue area demarcated by the green arrows is the part of the infundibulum enclosed by the turbinal uncinate process. And he has named this the turbinal infundibulum. If we go to the second picture and look at, well, let me show you up here. This is where the ethmoidal uncinate process attaches and goes forward under the cover of the middle turbinate to attach to the frontal process of the maxilla right there. So if we turn this a little bit in the next photograph and we look at the yellow arrow, you're looking into the turbinal infundibulum here, and we can see where the ethmoidal uncinate process has its opening for the infundibular space of the ethmoidal uncinate process up in this direction to be in direct communication with the ethmoidal infundibulum and the turbinal infundibulum down here. Then in the next picture, Dr. Zinreich has removed the medial surface of the Agger Nasi cell. Oh, there comes that term again. So what we have referred to in the past, and it's our common language, the Agger Nasi cell, we now can see is the three-dimensional development of the ethmoidal portion of the uncinate process. And this is the posterior face of the maxilla or frontal process of maxilla. And then attached underneath is the turbinal uncinate process. And now you can begin to appreciate the three-dimensionality of how the frontal sinus drains into the frontal recess over the top of the infundibular space of the uncinate process, the ISEUP, the Agger Nasi cell. And you can see how it empties directly into the infundibulum here. What you can't see well, if we go back this direction, is that it's emptying medially over the ethmoidal uncinate process between it and the middle turbinate right here. So it empties medially over the ethmoidal uncinate process, and it empties posteriorly into the ethmoid infundibulum in this specific pneumatization pattern. I want to caution you about that because we already have one paper in the literature that shows many variations beyond this, and there's another one coming that's even, I hesitate to use the word bizarre, but in our old imagination, it's amazing what he's been able to find. There are three additional categories that he has found. So we'll just quickly drop down to the lower part and I'll let you use your imagination here, but you can see we've got further into this specimen, elucidating the anatomy. This is another structure he's identified that we didn't even know existed called the common lamella. This structure is deep to these structures, to the bulla lamella or face of the bulla and the uncinate process, particularly the ethmoidal part of the uncinate process. Those are these two lamellae here and here. As you go farther laterally, fuse into one, which ultimately attaches to the lamina papyraceae. So I think everybody's brain probably needs a moment to rest. So don't try to absorb too much right now, because I know it's taken me the best part of 3 years to get to where I am in my understanding of this. So I want to back up now and talk about something you are familiar with and give your brain a rest. We'll talk about frontal cells rather. I'm not going to try to talk about spaces right now. I want to get back to familiar language. And please remember, we're not trying to get you necessarily to change your language, but your concept of what that language represents. So when we first began noticing these unusual cells that were pneumatizing into the frontal recess and frontal sinus above an Agger cell, starting somewhere in 1991 or 92 at the Medical College of Georgia, it became apparent that there was more than one presentation of this. So we took the several presentations we had, and it was easy to call a single cell above an Agger cell a type 1. A tier of 2 or more cells, it was easy to call a type 2 because there were at least 2 cells above the Agger cell. And then we came across this other unusual one, a single large cell attaching to the anterior frontal sinus table. So we decided to call that a type 3. And this relatively rare thing that was a single cell that was seemingly isolated with no obvious connection to the frontal recess and did not appear to attach to either the anterior or posterior frontal sinus table. We lumped whatever those were that we came up with into type 4. So here is a coronal radiologic picture of what these cells look like. Now, please remember that in 1991, 92, 93, and 94, we did not have sagittal reconstructions available to us. Let me rephrase that. We did not have usable sagittal reconstructions available. So we only were going on the basis of coronal scans and axial scans. So here you see a large Agger cell on your left with a smaller cell above it pneumatizing up into the frontal recess and maybe even into the frontal sinus. So that's a single cell or a type 1. In the image on your right, you see a very small Agger cell here, and above it, a little bit larger cell, and above that, a much larger cell pushing against the interfrontal sinus septum and seemingly attaching to the roof of the orbit with an opaque frontal sinus above it. So that's 2 cells that qualifies as a type 2. A type 3 is a little iffy on coronal view, but it's a large cell up in the sinus and somewhere lost in all of the edema and polyp formation down here. There should be an Agger cell. And here's a type 4 that seems to be an air bubble in the frontal sinus. This one looks like it might attach to the anterior table, but we don't have any way to really discern that looking from medial to lateral. Here's a different type 3 frontal cell to show you the well-formed Agger cell, the type 3 cell, and to look at the direct sagittal CT because this was an anatomic specimen, not a patient. And we can see that it's attaching to the anterior table of the skull. The really strange thing is that it seems to come down here and it looks like the basal lamella of the middle turbinate. But we know that can't be because the middle turbinate basal lamella is supposed to attach to the skull base somewhere around the anterior ethmoid artery. So Dr. Zenreich is listening, and I will prevail upon him to look at this lamella and come up with his guess on a single sagittal CT scan of what that might represent.
Thank you.
So as we look, go further, yes, somebody said something.
Do you want me to comment on this or
Saad,
not?
what do you think? I
Go
think
ahead,
not
Dr.
now, Jim,
Zenreich.
perhaps later.
Okay,
Saad, what do you think?
no problems. Dr. Zenreich, you can comment. Go ahead.
Great.
Can you
We'll
go
go
back
back
to the
to-
previous slide? That's
Yeah.
it. Okay, where you have the 3. Now, let me do this. Okay, you can't see my pointer, can you?
I cannot, unfortunately.
Okay. What
Show me
you're
where to point.
okay, right there where you are. Don't
Yes.
move. Okay, that is the bulla lamella.
Oh, whoops, just a minute. Yes.
Has this patient had surgery in the past?
No.
Okay. Because what I'm suspecting is that here we have an ethmoidal cell going into the frontal sinus. And higher up, if you take that right, come down a little bit, come down a little bit, come down a little more. That's where the common lamella is, a point of fusion between the ethmoidal, the uncinate lamella and the bulla lamella. And then we have a continuation, as you see, going right to the anterior frontal bone. And we see that in a frontal ethmoidal cell or space. This is what I prefer better.
Right.
The issue is that the planes, the CT scan is not as good in this particular instance to show you the communication. I suspect that there is a lamella starting from where the black arrow is going to the common lamella, indicating an incomplete cell, if you will, communicating with the proper Agger Nasi cell, where that black arrow is.
Yeah, Jim, can I interrupt?
Yeah.
As I'm looking at this, I see a faint shadow here, which probably is the uncinate process.
That is definitely the uncinate process.
And this is probably the back wall of the Agger Nasi cell, which would be the ethmoidal infundibulum.
Right. Your pointer previously was right on the superior nasal spine.
Yes.
And, the uncinate process is coming off of the inferior nasal spine, or
right here,
better defined as the tip of the inverted isosceles triangle of the frontal process of the maxilla, extending posteriorly to the posterior fontanelle.
Yeah. All right.
So what you're dealing with is a frontal ethmoidal cell in this case.
Right. So we're learning new things about some of our old terminology, and we'll move on now to the supraorbital cell. One of the fascinating things was to get a CT scan like this and try to understand what the ground glass appearance was in it. And suddenly it dawned on me that it was airborne averaging between the roof of the orbit and the air in this lateral frontal sinus, if you will. But then we looked at a CT scan, an axial cut lower, and that airspace lines up behind the frontal sinus, and consequently this represents a supraorbital ethmoid cell pneumatosed out over the orbit. And if you do a coronal cut through here, you'll think that the frontal sinus has two parts. So this is a fully dissected lateral left nasal wall of a cadaver. You can see the frontal sinus opening here, the lamella of bone, which is probably the bulla lamella, separating the frontal sinus from the supraorbital ethmoid cell, which is just an enormous cell extending all the way back to the sphenoid. I've seen as many as 5 or 6 separate supraorbital ethmoid cells in both patients and cadavers. This is a patient that had been operated on, was sent up to me. I quote unquote rescued him. And 6 months later, he came back with continuing sinus drainage. And so I thought maybe I wasn't quite so smart as I thought I was. We rescanned him, and his right frontal sinus was opaque, of all things. So I looked with a telescope, and I thought, well, there's the supraorbital ethmoid cell. That's supposed to be the frontal sinus, but there's all this edema up here. If you'll notice, there's edema posteriorly here as well. So we took him back to the operating room and found a cap of a cell anchored laterally, which was obstructing the frontal sinus, slipped curettes around it and fractured back the eggshell of that cap, took it out, and that's all we did. And 24 hours later, this is what he looked like. Wide open frontal opening, No edema in this anterior supraorbital ethmoid cell, no edema posteriorly. But there you have how a supraorbital ethmoid cell can completely mask and hide a frontal opening if you don't have some way that you can either suspect or find your way around that. This is where image-guided surgery is a real help. Pardon me. Now on to frontal bulla cell. Martin Citardi described this cell in a paper after he was back at St. Louis University. And you can see that this is the bulla lamella probably. Could be the middle terminate basal lamella because that's anterior ethmoid artery. But nonetheless, this is a suprabullar space that's pushed up into the frontal sinus from behind. This, in my estimation, is the single most difficult case to solve endoscopically of any of the frontal cells that we've described. My resolution to that was to poke a hole, make an opening through this with a plain-ended 90-degree frontal ostium seeker, enlarge the hole, and then put a 90-degree seeker in there to pull out the pieces, and finally debride that cell wall cap and open up the drainage pathway out of the frontal sinus. As opposed to that, over here, we see a frontal sinus with edema overlying what we would have called a suprabullar cell, because that cell really wasn't yet up into the frontal sinus. Now this, in contradistinction, Hans van Alje, in a book in 1951, has this image, and they're drawings. You can see anterior frontal sinus table, frontal sinus floor, posterior table, and laterally in the floor of the frontal sinus is what he refers to as a frontal bulla. You can see in his drawing that this straw or arrow that he puts in here appears, well, it's going either to the bulla or it's into the frontal sinus. I suspect this is intended to be in the frontal sinus, and one further down and more lateral comes in to the bulla. And this is a cadaver specimen that I have that we transilluminated from behind. We're clearly looking into the frontal sinus from medially, and here is a bulge in the lateral floor of the frontal sinus that matches up relatively well with what Van Alje described. This is a very infrequent finding in my patients. A quick look at a suprabullar cell. It's medial at the skull base. It's above the bulla. And here's that patient operated. To right side, you can see the frontal sinus is widely open. The partition between the supraorbital ethmoid cell and the frontal sinus that probably came about across here has been taken back so as to make this a unified drainage pathway. And then medially, we can see where the walls of the suprabullar cell were taken down. You can see its bed. Lastly, we'll go to the interfrontal sinus septal cell. This is a left side of a previously operated patient with a wide open suprabullar cell, supraorbital ethmoid cell, a frontal sinus that is occluded by scar tissue, and a nascent, not fully pneumatized interfrontal sinus septal cell going up medial to the frontal opening. Sometimes it's actually anterior to the frontal opening. Now my partner, Dr. Chris Milroy, made this video and gave to me that I want to play for you so that you can see what he found in a hidden interfrontal sinus septal cell. That's frontal sinus that you see open right here. And as he's aspirating away blood and looking, all of a sudden he drops into a more medial and somewhat more anterior cell that you'll see in a moment after he resects the bony partition in between with a side-biting 90-degree frontal sinus punch, that this is indeed more anterior medial opening into the interfrontal sinus septal cell. So here's the coronal CT image showing that there's a similar situation on both sides. But as you go back to this, it's pretty clear that that can be done with curettes and punches and does not need to have any kind of powered instrumentation. So this has been a fairly dense and long journey through the highly variable and complex anatomy of the frontal recess, the anterior ethmoids, and somewhat the frontal sinus. So the questions that arise are, how do we organize this to safely operate on these patients? What procedure do we use? What instruments do we use? Do we use through-cutting punches or some kind of powered instrumentation? Well, if we stop to go back and remember David Kennedy's acronym of FES, Functional Endoscopic Sinus Surgery, we need to go back and think about this word functional. What does that mean to us? It means endoscopic sinus surgery that's used to restore function to the sinuses and at the same time preserve structures and mucosa. This is an extraordinarily important point that many of us forget, the mucosa. Dr. Murayama, who happened to be one of Joseph Ogura's fellows while I was a resident there for 4 years, left and went back to Japan and became a departmental chairman and did some extremely nice work, which particularly by about 2000 was published. And he did electron microscopy on mucosa samples where the mucosa had been stripped off and allowed to regrow. And the reason I want to insert this here is because I've seen many instances, I've had it happen to myself, where you inadvertently peel off mucosa with one of your instruments and you can't really put it back, or it's gone up the pipe on a debrider, and you cross your fingers and you put something in there to try to protect the area for a while. But what he discovered is that once cilia has been stripped off and allowed to regenerate, the mucosa may regenerate, but it is very poorly ciliated. The cilia do not regenerate. So we have to keep that concept in mind by choosing how we go about doing our surgery. So how do we find our way into this frontal sinus? Well, you must learn the anatomy and understand the embryology. Under Jim Zunreich's tutelage, it became obvious to me that I needed to learn how to interpret my own CT scans, because the radiologists would give me a reading, but they really didn't know what they were seeing. And they definitely did not know how to relate what they were seeing to the surgery I wanted. So become your own best radiologist for your patients. By all means, image guidance now in surgery has become a must if you've got any kind of a difficult case. If you're trying to work in the frontal sinus and the frontal recess endoscopically from below, once there's blood in there, once there's a lot of edema or there are polyps, you can't see the anatomy. You need some help that will show you where you are so that you don't get lost. Identify landmarks, follow Walter Messerklinger's admonition and go low from anterior to posterior until you reach the sphenoid face, then go up to the skull base and come from posterior to anterior. If you don't have reverse light post telescopes, get rid of the ones that you're operating with and immediately get a reverse 30 and 70 degree telescope. It will make all the difference in the world to your ability to work around that light cord. So the next thing is to come up with an integrated approach utilizing all of the useful surgical procedures we have available to us, but to organize them into a fashion so that you can apply them as needed by the patient, working from the least invasive to the most invasive. So in September of 2005, 16 years ago, 15 and a half years ago, the balloons were introduced by Clarent, and the concept of balloon-assisted sinusotomy hit the airwaves. All of you must be familiar with it by now. So that's the least invasive thing that we can do. It's not useful for every individual, but in many it is. For those that it's not, then the next step would be endoscopic, intranasal endoscopic frontal sinusotomy. The next step up the ladder would be a frontal sinus rescue procedure. And again, this is for people who have had their middle turbinate removed and their frontal sinus is scarred over. An above and below approach, combining a frontal sinus tree find and an endoscopic intranasal approach. The next step up would be an intranasal modified Lothar procedures. And I would urge you, if you're doing this procedure now, please make the attempt to change and try to do it with the through cutting punches that are available as much as you can possibly do it. Then the next degree of invasiveness would be an above and below approach, combining an osteoplastic frontal flap with an endoscopic approach in preserving the frontal sinus outflow tract, stenting it if necessary. Way down the list would be an unobliteration, and we've done 50 or 60 of those, and you can do it successfully. Presuming that once you get the frontal sinus open, you find some shred of mucous membrane left in it. And then the osteoplastic obliteration, which in my hands is extremely rare and a terrible first choice in most people. Now, let's spend a moment on the unobliteration because I'm not going to talk about that further. But why would you do an unobliteration? Well, you have a patient that presents to you who has been obliterated 10 or 15 years ago, and they're having acute frontal pain. And this is something that only came on relatively recently. Well, why would they be having acute frontal pain? Well, maybe they've got migraines. Well, I suggest that that's only one possibility. Having had enough of these people in a row, trying everything else that was possible, I decided to reopen their obliterated frontal sinuses to see if I could find anything in there. And uniformly, what I found was sequestered pus in an obliterated frontal sinus. You may be shaking your head wondering, really? Pus inside an obliterated frontal sinus? Well, I'll talk after a bit about instances in which this is very likely to happen. But I'll just tell you that I had one patient whose frontal sinus had a rectangle of bone taken out of the center of it, a big dollop of fat plucked in there, and the bone flap put back. And 15 years later, when I operated on the patient, I went back to look. Sure enough, there was scar tissue where the fat had been put. We cleaned that out and looked into the sinus, and the rest of it was totally mucosal lined, filled with pus. We irrigated it out, did an endoscopic frontal sinusotomy on each side, put in a stent coming down each frontal ostium, put the flap back, patient healed, took the stent out several months later, and the patient was fine with a mucosalized, refunctioning, pneumatized frontal sinus. That's the extreme. There are not many like that, but there are many who have somehow regrown some mucosa from a bit here and there that were missed in the process of trying to scrape out all of the mucosa. And so they became mucosalized spaces filled with mucus, develop EURI, somehow have bacteria disseminated through the bloodstream to it, and end up with a pus pocket and an obliterated sinus. So let's go on to balloon sinuplasty. This is in the early days when we were having to use radiology to help us see where the wire went and where the balloon went. This is the balloon in place across the frontal opening. Here you see it on the right-hand side with contrast material inflated so that we can see it, and you can see how much it has opened that particular drainage pathway. So this is one specific patient that had an opaque frontal sinus, had this massive cell pneumatized up into the frontal sinus, passed the wire and the balloon up and dilated and let down the balloon 5 or 6 times all the way across here. And here he is 6 months later with a fully pneumatized frontal sinus, and you can see how much room we gained. There's another picture that I have further back showing the drainage pathway. You couldn't see the drainage pathway at all pre-op, and post-op there was definitely an air-containing space back there. This is another individual that showing the cannula placement, showing the frontal recess after the balloon was inflated and removed. You can see that we're looking at the roof of the frontal sinus. 2 weeks later, this tissue had pushed back into a more normal position, revealing that it was the medial wall of an Agger cell that had been crushed over by the balloon. So the Agger cell is back open and functioning. Mucociliary clearance is coming out of it and also out of the frontal recess. Patient's doing well. Here we are at 3 months and 6 months. So you can see the stability of where the bone ends up and the patency of all the surrounding cells. So this technique is useful. Again, it doesn't solve every problem. Dr. Alsaleh and Dr. Javer asked that I show the instruments that we've developed. These instruments were developed starting in about 1989, and the first set was given to me in Graz in 1991. There are 2 curettes. One is about a 45 to 50 degree curette, the other is a 90 degree curette. And you can see in the drawing that it's intended to go up against the skull base over the top of cells pneumatizing the frontal recess so that they can be fractured down and removed with these giraffe forceps. So it's just a picture of a side-biting 90-degree giraffe forceps taking out a fragment of bone. And so that's the way to delicately and gently work in the frontal recess and treat it like you were an otologist working in the middle ear. The reason for that is to preserve all of this functioning mucosa without damaging it, so that as soon as the patient's healed, the mucociliary clearance is back working again. This is the original seeker that was designed. It has a 45 to 50 degree end on it, and you see an internally bent ball tip on that end where this one's straight. And again, its purpose is to be able to pull and move around fragments of bone. So something on the order of 10 years later, I decided to ask Carl Storch to design a new set. And this is a set of frontal ostium seekers that are designed to, the 90 degree end and the 50 degree end. Each will have this ball tip bent at a different angle. So there will be one to the right, one to the left, one anterior and one posterior, so that you can fit all sorts of angles and sinuses. And then we designed a set of through cutting punches, 45 and 90 degree, opening front to back and side to side. And then there have been several iterations of that. This is the most current iteration here. And the jaws break less frequently on these than they did on the 2 previous iterations. But these are indispensable in taking out small lamellae of bone high up in the frontal recess and even in the frontal sinus itself. So we moved from balloon sinuplasty now to the endoscopic approach. This is an example of an Agger cell, an opaque frontal sinus. We look a little further back. We can see that we have an Agger cell with opacity above it. And if we look at a little bit further posteriorly, you can see how far back the edema goes. And then if we look at the sagittal, we can see what the underlying problem is. We have one cell pneumatized from anterior that we would call the Agger cell, or perhaps the infundibular space of the ethmoidal uncinate process, lying against something like a suprabular cell. And this common pairing of the two walls is where the obstruction is. So that's what needs to be taken out, or dilated with a balloon if you can do it. This is a large type 3 cell pneumatizing way up into the frontal sinus. Scan a little further back. Helps to look at the sagittal CT, and you can see what you need to take out looking at the sagittal. So it gives me a reminder to suggest that if you're not utilizing your sagittal CT scans yet, that's the next best thing I can suggest to you that you put into your practice, is to really look at the sagittal CT scans to understand the anatomy. So this is that same patient, and it will explain to you why a 30-degree telescope doesn't tell you the whole story. So it doesn't look bad. The middle meatus is open, and you might let it go at that. But if you look with a 70-degree telescope, you put it in a little further and look up, all you see is polypoid edema. You don't see any real structures. And so if we move on to the next slide now and look at the post-op picture, this is what a 30-degree scope will show you from anterior, and this is what a 70-degree telescope will show you from interior. You can see about this much with the 30. So you can see the roof of the frontal sinus and reassure yourself that everything's really okay up there with the 70. And you can look with the 30 and say, oh, well, that frontal sinus looks good, which it does, but you're not checking up here. So remember to begin looking beyond the obvious, and eventually you will begin to see things that you were missing. So this is something we've termed a type 4 frontal cell. It was a patient who was 3 months post-op from an inverting papilloma of the right ethmoid. The procedure was terminated secondary to bleeding at that time. He healed up. We also learned that his middle turbinate had been resected for the tumor, and he still had residual frontal sinus disease, and we couldn't see into the frontal sinus. So in surgery, now going back, well, I won't go back. Here it is right here. Let me go back. Going back to here, you might be tempted looking at this mess here. Well, I just need to do a Lothrop on this. And you certainly could, but if you can look endoscopically with 70-degree telescopes, 90-degree suctions, 90-degree curettes and instruments, and grasp this bony cup with a giraffe forceps and take it out and look back and see this, why would you need to drill that? Isn't it much more elegant to be able to do it and leave as much of the normal anatomy alone as possible? Now, if you get this far and you look at it and say, oh, I'm afraid that's going to scar over, well, what you can do is you can put a very simple stent in there that you can make on the operating table that we'll show you in a few minutes. You can leave that stent in for 2, 3, 4, 6 weeks if you want, and you can easily remove it in the office with a giraffe forceps. So in conclusion, the endoscopic approach is useful even in the most difficult cases, including revisions, and there's no need to risk the tissue damage of a drill in most cases. But you must understand the anatomy and how to do the approach. You must have the right equipment, and you must do the postoperative care in the office. So I recommend in course of doing your procedure to avoid the skull base, go posterior first, come up where you can recognize the skull base, come forward until you can locate the anterior ethmoid artery, dissect from posterior to anterior and medial to lateral, not lateral to medial, or you may create a CSF leak medially. Use a delicate stapes-like technique. Use through-cutting punches. Avoid tearing the mucosa. Use image guidance and check your location. Now on to the next order of invasiveness, and that would be the frontal sinus rescue procedure. In 1996, we had a patient come in whose middle turbinate was resected. The inside of his nose looked fine and his frontal sinus was opaque. When you looked in there, the lateral nasal wall was smooth right over the Agger Nasi region, but there was absolutely no access to the frontal sinus. So the options appeared to be either obliterate this frontal sinus or get out the drill and drill it. So I scratched my head, talked it over with Martin Citardi, and I said, we've got to try something different to see if there's another option out there that we haven't figured out yet. In order to do the rescue procedure, you have to identify the frontal recess, which you can do with a seeker and you can do with image guidance. Then we resect the middle turbinate remnant up to the skull base, at the same time creating a frontal recess mucosal flap and a nasal mucosal flap on that turbinate remnant. Then if we return to our plastic surgery scar revision training in our residency program, or even when you might have been on general surgery, you know that one of the key things for revising a scar is to break up a circumferential scar or to do something to disrupt a linear scar. So here we have a 37-year-old male that had had 4 previous sinus surgeries in 10 years. In the preceding year, he'd had stents, Raines stents, relatively rigid silastic stents pushed up into the frontal sinuses 4 separate times, continued to be infected with MRSA, and needed a new idea. So this is what the sagittal reconstruction looked like of a CT scan. Here, this ledge of bone, edematous purulent mucosa, stent, tight opening, nothing's getting out except the ooze. Same thing on the other side, only on the other side, there's this massive osteoneogenesis that's taking place. So going back to Professor Messerklinger's fresh cadaver studies in the 1950s, we remember that the mucus clearance pattern in the frontal sinus is up the interfrontal sinus septum, laterally across the roof, and then medially back across the floor of the sinus or roof of the orbit and down the medial aspect only of the frontal recess. Mucus doesn't come down the lateral aspect, it goes up. And because of the fact that this loop can extend this far down in the nose is one of the reasons bacteria gets up into the frontal sinus. That's just an aside. Doesn't have anything to do with the procedure itself. Remember, if you're going to drill this, that the drill bit not uncommonly destroys this mucosa. And if it's destroyed, it will not regrow with its normal ciliary clearance pattern. We all remember that pus doesn't come out of a sinus by gravity, it comes out by mucus clearance. So in this diagram, this is the way the patient presented. The turbinate remnant was adherent to the medial orbital wall. So the first thing we did was identify that spot and penetrate it and make an opening into the frontal recess, the length, anterior posterior length of this turbinate remnant. Then we dissected the mucosa off of the turbinate remnant to this midpoint, which gets us to picture number 3. And we also separate the internal mucosa from the bone at that point. Once this is resected, we try to carefully resect this mucosal flap up to this point, then resect the bone, and then take this mucosal flap and turn it up into the roof of the nose. Normally, the amount of blood that is accumulated on the back of that flap will serve as an excellent tissue glue to hold it in place. So then what we've done is we've broken up the circumferential scar by turning a rectangular shaped flap up into the roof of the nose. We can stent this, if we wish, with a flexible celastic stent and restore the mucus clearance down the medial orbital wall. So here's this patient. So here's what he looks like intra-op. This is anterior, posterior, medial orbital wall, middle point of the opening. And so this is somewhat of a supraorbital space. And what we've done is turn a flap here up into the roof of the nose. That's where the bone plate's been removed. And here's what he looks like 18 months later. So we've gone from no opening with a semi-rigid stent in it to an open functioning opening into the frontal sinus, and the mucus clearance can come right down the medial orbital wall. Now, so the next problem that confronted us was sometime between 98 and 2002, and that was a patient who still had their middle turbinate, but there was either little or no room between the middle turbinate and the medial orbital wall. Some of them were scarred, some of them were just edematous, but we could not reestablish drainage from the frontal sinus because of the close adherence of the upper part of the middle turbinate to the medial orbital wall. So we came up with the idea that, well, we don't want to sacrifice the middle turbinate. So what could we do? And the thought occurred to us, well, we could convert this to a frontal sinus rescue procedure if we simply took out a narrow channel of bone right here that would preserve the middle turbinate and yet give us access to the frontal sinus like we were doing a frontal sinus rescue procedure. So here is a prime example of what I'm talking about. This poor patient is very edematous. He's also very scarred. So we cut a channel up the middle turbinate to the skull base and came forward and took all this down and did our frontal sinus rescue procedure on him. And you can see 18 months later, he had a small functioning ostium. Now, believe me, I would have been very pleased to leave it that way if he didn't have disease on the other side that needed to be operated on. So we didn't just go fix this to make good better. We were going back to the operating room anyway. And so we decided to give it another go. And this shows you a perfect illustration of what that rectangular mucosal flap looks like turned up to the skull base. And you can see how clear and nice, even in the operating room, the inside of that frontal sinus looked once we got it opened. And then even more amazingly is a picture we took 24 hours later. And look how good the mucosa looks. Look how well the flap is stuck in place. Excuse me. I think I'll be able to go on without taking a break. So this is where he started out. This is where we have ended up a year and a half later. So you can see how much turbinate's left. You can see the part that was taken out. If you'll excuse me for just a moment. So now moving up the invasive ladder a bit further, we'll go to the above and below approach. Dr. Alsaleh, I think I'm going to have to pause for a second. If you want to take over.
Oh, no problem. Yeah, it shouldn't be a problem. We can definitely take a few minutes as a break. We actually have a few questions we could actually chat about. One of the questions was before going into the surgeries itself was about the clinical implications of the frontal sinus or frontal ethmoid cell classification.
I'm sorry, would you go back again?
So the clinical implications of the classification of the frontal ethmoid cells and how would it actually change your surgical techniques?
Okay.
What are your thoughts on that before we continue?
I think the importance of it is so that you have an idea ahead of time what it is you're going to be facing in the operating room and what you should be looking at when you get in there. A quote unquote simple Agger Nasi cell, meaning one that's of moderate size that doesn't extend up into the frontal sinus or the frontal recess. If you knew that's what you were dealing with, then you would know that if the disease was isolated to the frontal sinus, that all you need to do is get into the anterior ethmoids, find the posterior and medial wall of the Agger Nasi cell, fracture them down, take it out, and you're finished. Whereas if you have a complicated pneumatization pattern in the anterior ethmoids, and you have no posterior ethmoid disease, and you're only after the anterior ethmoids and frontals, you can make a similar approach, but you would be anticipating having a much more difficult time figuring out which bone fragments need to be fractured one way or the other and which need to be taken out to finally gain access to the frontal sinus. If you add posterior ethmoid disease on top of it, then that has its own set of complications and rules and processes you go through. But if you can categorize in your own mind, and it's not necessarily important for you to fit every patient into a classification as it is to look at the patient scans very, very critically to decide what the pneumatization patterns are so that you'll have some concept of what you need to do in the operating room. Did that help?
Definitely, and having a common language is always helps, at least between us rhinologists, to talk about what we need to do during surgery as well.
Right.
And another question about the frontal rescue procedure, and you showed some of the beautiful images on how to do the flap. What do you do afterwards? After doing it, do you actually leave a spacer in that area? What's your usual post-operative debridement course?
Show you. There's a good answer to that. We'll just use this inflated example. So I personally usually stent these, and I'll show you how to make the stent a bit later on. But you would tuck the stent up in here. It unfurls up in the frontal sinus and hangs there in a tube shape. It's flexible, so there's nothing pressing on the wound. The wound heals nicely. If I had operated on the middle meatus, I would put a middle meatal spacer in below it. That would come out in a week. The stent I would leave until I was happy with the way the mucosa looked up here. And then I would just reach in with a pair of giraffe forceps and slip it out.
Perfect.
Is that enough? Is that enough of an answer?
Yeah, definitely. And how long would you keep it?
The stent?
Yes.
At least a week, and I've gone as long as 2 or 3 weeks. The only reason it's being stented is to give yourself some comfort that this part of the ostium is going to stay where it is because you haven't disrupted anything back over here. All you have to do is wait for the edema to go out of this. This is the part that needs to heal up here. So once that's healed, then this thing is functioning again.
I definitely agree. And I personally have used chitosan gel spacers in that area for a week or so, similar to what you do as well. And I've found great results with that as well. It leaves
If we go back to this picture, we didn't send this one. This one was functioning perfectly 24 hours later. It was actually functioning right here in the operating room because the only thing that was disrupted was this. All this other mucosa was perfectly healthy. But you know, you tailor what you're doing to your given situation.
Perfect. Would you like to continue on, and we'll get to the questions later on?
I think I'm through that little bit of spasmodic coughing.
Perfect.
So now there are occasions when you need to work inside the frontal sinus as well as coming endoscopically from below. So if you need to do that, then you can make a tree fine through the anterior frontal sinus table by making an eyebrow incision, and then you slide the incision up over the brow, drill your hole through the anterior table, and then you can put your telescope here at the outer edge of the table so that you can look into the sinus and pass your instruments in underneath it. If need be, you can actually put the telescope in there. So since we're working with 4mm telescopes, you need about a 5mm diameter opening, and that gives you plenty of room to get your instruments in there and manipulate them. The other thing that you can do is put your instrument in this way, and you can pass your telescope this direction and watch what the instrument's doing, or you can do vice versa, as in this image. So here's an example of that. This is a patient who had a modest size osteoma in the frontal sinus. It wasn't up in the major part of the frontal sinus, but it was too big to reach, fracture loose, and pull down from below. So our solution to that was to make an eyebrow incision, and this is post-op, so you can see how well it's healed. Then we slid the tissue up to about here, made a drill hole into the sinus over the osteoma, fractured the osteoma loose, and tried to push it down into the frontal recess, but it was too big to go. So we scratched our head, came back and looked at it. We pushed the osteoma back up into position, held it, enlarged the tree fine a bit so that we could hold the osteoma in place. And then we took a 2 or 3mm drill bit and drilled the osteoma in half. And then we could drop each piece down through the frontal recess into the nose and take it out. And all we had to do was put the periosteum back together and suture up our opening, and we were done. So that's one way to use it. This is another way. This young woman had had a previous osteoplastic flap, and you can see it here on the left-hand image. But as you cut back in with the coronal CTs, you can see that there is an opaque space lateral to her pneumatized frontal sinus. This is something that is lateral to the bone cut on the osteoplastic flap. You go back further and you can see it's further away from where that bone flap was. So we made an eyebrow incision. We pushed it up above the brow ridge, drilled into the sinus, only we didn't drill into the sinus, we drilled into the opaque space, because here you can see the lateral extent of the bone flap. So we've drilled into that space, aspirated the goo that was in there. Then we could look in and inspect it. We could look in and pass a curette in here, or we could put our telescope in and see what was over here. Once we determined that there was a bony lamella there, then we could keep the telescope outside, pass our curettes in there to fracture it, and pass our giraffe forceps in to take out the pieces. We could also look up from the intranasal side and observe what we were doing and monitor what we were doing. And if we needed to do more from the nasal side, we could watch what we were doing through here. So here's the finished product. This is the opaque area. This is where the bony lamella was attached to the orbit. And this is where the bony lamella was attached to the anterior table of the frontal sinus. You can see we've removed it all. And then if we look up from below, we passed a seeker through the tree fine, and here are the edges where we removed the bone. So we could stent that. We have the endoscopic approach wide open with healthy mucosa. And so we were able to put that back together. I'll go back to it here just a second. So we were able to put all this back together and know that we had a safe sinus and we could follow it from below endoscopically. So that's the endoscopic and tree fine approach. So we've alluded to the Lothrop, and I've talked about this, so we won't belabor that slide. This is a sweet lady I had when I was at MCG, who had many procedures and still had chronic frontal sinusitis. You can see everything had been removed from her nose, all nasal structures, even part of the nasal septum anteriorly. Nasal septum's gone between the two sinuses. So we have proverbial snake eyes with the left and right frontal ostia, or openings. So I didn't really want to do this with a drill if I didn't have to. So I just started working in her left frontal sinus with frontal sinus punches, the mushroom punches. Professor Hosmann's beautiful frontal sinus mushroom punch, which is one of the mainstays of our armamentarium. And we just finally used all sorts of different punches to get our way across this bridge of bone and finally open up both, and this is her healed result. A nice horseshoe up there. Everything is mucosalized, everything functions. Now, there comes a time when this bone up in here separating the two sinuses is so dense and so thick that you don't have a punch that will break through it without breaking the punch. And so occasionally we use a drill in the midline to take that up, but we stay completely away from the lateral parts of the sinus with the drill because we want to be sure we preserve this mucosa. So I've talked about stenting. So I had these slides and looked at them, and I could hardly distinguish between the celastic and the towel. So I went in and put some outlines on this celastic so you can see it better. But in general, a 1 by 2 centimeter piece of 1/100th inch thick celastic sheeting is perfect for these stents. There was a lot of work done 50 to 100 years ago on rigid stents, and they are not good to use in the frontal sinus because they induce osteoneogenesis where they're putting pressure on the wound. So way back then, the Mayo Clinic determined that we needed to be using flexible stuff. So you simply make a little cut into the top of it like this, and then you tube the bottom half of it, and these are wings. And those wings are what support it inside the lumen of the sinus. So here we have the tubed silicon rubber sheeting. And hopefully this will show you how to put it in. So you use a 90-degree giraffe, slip it into the nasal cavity, and then rotate the giraffe to get it to go up into the frontal recess. So there it's going up into the opening. And now the trick is, how are you going to turn loose of it? So you have your assistant hold the giraffe. You take a 90-degree plane-ended frontal sinus seeker, position it yourself so that it will hold the stent in place. Then you give the seeker to your assistant. You hold the giraffe, and then you slide out the giraffe while the assistant's holding the seeker. You trade again. You drive the telescope with your offhand and use your dominant hand on the seeker, and then you can position it where you want and carefully withdraw the seeker so that it doesn't pull out the stent. And you can reposition it if you wish. We'll go back and look one more time here just to make sure. So it's sitting nicely in place. And then you just leave that there. And you leave it as long as you feel like you need to. So what I want to caution you about is, out of the many stents that I've put in, there were probably 3 patients where the stent migrated up into the frontal sinus. They don't seem to cause much of a problem. I'm embarrassed to tell you that I found 2 of them over a year later, but I was able to get them out and the patient didn't suffer any consequences. The 3rd one I was able to find and retrieve earlier than that. You have to suspect that it's there, but if you miss it, it's an inert substance, and as long as the patient's not infected, you won't notice it probably. So if you look at the lower tier of pictures, you see this funny looking t-shirt and pants looking thing. Well, this is a piece of thicker elastic that's about 1 centimeter to 2 centimeters wide and about 3 centimeters long. And it's cut with a V in the top to fit across or around the interfrontal sinus septum. You have an arm going up this way to go to the right frontal sinus, an arm up this way to go to the left frontal sinus, and a notch in the bottom to fit over the septum. So this is the stent that's used in a modified intranasal Lothrop that we did with punches primarily. Probably used a little bit of drill in the midline, but the mucosa looked so rough that I wanted to be sure that I stented that. And so here you see the stent straddling the nasal septum here. This is the slot in the middle with an arm going down the right nostril and the left nostril, going up into the left frontal sinus, the arm going up into the right frontal sinus, and then this is on the right side showing the same general thing. So that's how you can stent an intranasal modified Lothrop to try to give you a little more leverage or advantage in not developing scarring of the frontal sinus. The reason I'm bringing that up is because one of my early fellows told me that when he went back to his university, he was presented with some patients that had had intranasal modified Lothrops done, and the 2 of them were women, and they developed severe unremitting headache. They had stenosis that he couldn't fix, and they both ended up committing suicide over the headache. So that's not a common occurrence. I share it with you so that you will know that there are downsides to using a drill on the mucosa. So now combining an osteoplastic flap and an endoscopic approach. So there are problems that occur in the frontal sinus that require that we open it, but we do not always have to obliterate after we do an osteoplastic flap. If we can preserve really good mucosa in there, We can always put stents in here and bring them out into each nasal cavity, and we can leave them as long as we want to leave them. So you do your endoscopic frontal sinusotomy approach first, and then you do your osteoplastic flap, and you remove your disease, whether it's a mucocele, whether it's a tumor, whether it's some kind of cellular stuff like eosinophilic chronic rhinosinusitis / allergic fungal sinusitis. The key things about these elements are, it's almost impossible to make sure that you have removed every shred of mucosa from the inside of the sinus. If someone has a tumor that you're operating on, you're far better off being able to follow that patient with CT scans and with your telescope from below if you can preserve the pneumatized functioning character of the sinus. Then you'll be able to follow them if you obliterate it. If you obliterate the sinus in a patient with a tumor, how in the world are you going to be able to follow that radiographically? And you definitely can't follow it endoscopically. Let's say it's allergic fungal sinusitis. How can you possibly be sure, after you've taken out the polyps and the allergic mucin, that you have removed every shred of fungal hyphae and cellular material, and know that that is not going to recur once you have obliterated it? I've dealt with one of those too. So the real secret is to preserve all normal mucosa. Make sure you've got a good wide access from below, and then create stents with thin celastic sheeting. And I would use the 100th inch thick celastic sheeting. And you can make a stent that fits the perfect outline of your sinus and leave a long rectangular tag on the end of it that you can pass down into the nose tubular wise. And even if you don't remove the intersinus septum, you can pass one down one side, you can lay another one over the top of it and pass the pull-out part down the other nostril. It works very nicely to protect the inside of the sinus, allow healing to take place, and preserve the remaining mucosa that's in there so that you can have a functioning air-containing sinus that you can image and examine after you've replaced the flap and closed. So the advantages are you can remove the disease or tumor or repair a CSF leak. You can preserve and redrape the remaining mucosa. You can inspect it from above and below, put your stents in, replace the bony flap, and then you can image and look at it endoscopically. So now we get down to the most invasive of all, and that's frontal sinus obliteration. It's an operation that may still have some utility, but not often. We've explained so many other options that you have available to operate on the frontal sinus that there are going to be very few that you will need to obliterate. If you do that, you have to be able to remove all mucosa, make certain that you have removed it. Then you have to put in a good fat graft, and you have to seal off the mucosal opening to the ethmoid sinuses. But let me ask you a few questions. If you have an extensively pneumatized supraorbital ethmoid cell, how are you going to remove all the mucosa? If you have a missing posterior frontal sinus table from a mucocele, how in the world can you be sure that you're able to resect all of the mucosa from the dura? You can't drill on the dura like you can on the bone. Or if you have missing orbital roof from a mucocele and you have mucous membrane adherent to the periorbita, how will you deal with that? If you have a frontal sinus tumor and you obliterate it, I've already mentioned this, how will you be able to image that frontal sinus to know if you have a recurrence? And we've already talked about allergic fungal sinusitis. And if you have a CSF leak, why obliterate? Why not just repair it and treat it as we've done above? So those are all ideas for you to consider as you go forward. I'll leave you with this picture. This is what I would call a hyperpneumatized frontal sinus. I think most of you would agree. We're already back past the posterior frontal sinus table, and it's still going. And we're way back along the sides of the skull now. My colleague and friend at the Medical College of Georgia, Dr. Edward S. Perubsky, and I were co-residents. We were co-first-year residents in surgery, first-year residents in ENT, co-chief residents. And we were sitting doing one of Dr. Ogura's cases one day on a frontal sinus that was pneumatized like this. And we looked at each other across the table and said, how in the world would you ever obliterate this sinus if you had to obliterate it? You'd end up with mucoceles years later. Well, now we know that that's the fact. So I'll leave this with you as a visual image to take with you. And begin to leave you with some particular points. These are points that I have given to all of my fellows, some of whom I've been able to name today, but they're enough that I couldn't get all of them accounted for. But if you do not look when you're in the nose and sinuses, you will not see something. If you do not see something, you will not discover what's hiding from you. If you don't see and discover and find, you will not think about what you didn't see. If you're not able to think about something you could see, you will not then be able to innovate and create new solutions. Please remember that thinking connects you to the source of inspiration. So my final thoughts are, take multiple dissection courses. I had the great privilege of taking 4 and teaching in many more with David Kennedy and Heinz Stomberger and Jim Zinreich. So I had a significant advantage in being able to teach people the dissection. Make sure that sometime in your career you directly dissect a lateral nasal wall, not endoscopically, but you have the specimen in your hand and you can dissect the anatomy and look at it as you go to really understand it. Become your own best radiologist, study every patient's scans, take them into the operating room with you. By all means, encourage your institution to get image guidance for you so that you can be able to track where you're working and know what you've missed or might leave behind. Remember that functional in FES means preserving normal tissue. We don't sacrifice it in the interest of time or for ease of operation. We're there to restore function using a delicate technique. So the final thoughts are, remember to look beyond where you normally look. Observe carefully what you see. Think critically about what you're seeing and think outside the box of common wisdom. You have been given a magnificent gift to be healers. Your task is to use that gift wisely for the benefit of others. Remember that your patients are people and that your primary function is to relieve suffering and restore those people to the life and choices they had been given. So thank you very much for your attention. I know this was a lengthy lecture, but it sums up the great gift of things I've been given to learn about sinus anatomy, sinus disease, and how to go about taking care of the patients that I'm presented with. So thank you once again for your attention. I'll turn this back over to Dr. Alsaleh and Dr. Javer.
Thank you, Dr. Kuhn. A phenomenal lecture, and thank you for summarizing your lifetime work in one lecture. It's truly an honor to have you. And welcome everyone again from many countries, many friends and colleagues. I'd also like to welcome Dr. Martin Citardi. He actually joined us as well, professor and chair of the University of Texas, and he joins us as a panelist as well. Welcome, Dr. Citardi. And I would like to introduce Dr. Javer again. He'll basically just talk about some of the pearls of frontal sinus surgery and present a few cases. Go ahead, Dr. Javer.
Hello, Martin.
Hi, how are you?
I'm doing well. Good to hear you.
Good.
Thank you.
You can turn your video on. Yeah. I've got him in, but I don't have Martin.
Oh, Martin, nice to see you. How are you
Looking
doing?
good.
Doing well.
Excellent. So, Dr. Kuhn, that was an incredible lecture. Really enjoyed it. I think all those pictures of Savannah bring in some nice memories. So, had a wonderful time that we all spent with you and learned so much from you. So, I'm just going to give a little, a few of my thoughts on what you've spoken about, and then talked about one of the recent publications that we had, which I find very important. And one of the things that I find more and more is that the sagittal cuts are very important to analyze critically in the frontal sinus, when you're operating in the frontal sinus. And so we came up with a grading system called the frontal ostium grading system. And it's based on this concept where the more anterior the position of the frontal ostium is in relation to the anterior buttress, the more difficult it will be to access the ostium. And also the size of the ostium on the sagittal cuts is very important. So when you look at the ostium or the narrowest part, and Dr. Kuhn described this as one common sort of continuum of space, there's an area where you get a waistline between the frontal sinus and the frontal recess. And the position of this waistline is very important when you're operating. So if you look at the picture on the top right, you can see that the upswing of the skull base is more posterior to the anterior buttress. And we call that the frontal ostium positive or posterior position. And if you're anterior, if the upswing was anterior, you called it the frontal ostium grading negative. So it was either a FOG positive or a FOG negative based on where the upswing of the skull base was. And this really, I find, is very important before you start operating to analyze, because this will tell you how difficult your frontal sinus ostium and frontal recess surgery is going to be when you're in there. And you'll definitely need very angled scopes if it's a frontal ostium negative anatomy. Also, the diameter of this region is very important. So we divided it between 7 millimeters as being wide versus narrow. And this was based on 300 scans that we went through. So the anterior buttress, we call that the R line or the line that's always there. And then the upswing we call the S line. And if the S line was behind the R line, then we called it a FOG positive, and that made your dissection a lot easier. And you could determine this ahead of surgery, that was going to be an easy dissection for you. All right. And then there was others where the upswing and the anterior buttress and the posterior edge of the anterior buttress were exactly in the same plane, and that was a FOG neutral. And then there was those where the upswing was more anterior to the anterior buttress, and that we called FOG negative. And this would be the most difficult ones to transact and to dissect. So when we looked at our scans, and we looked at 300 scans, we found that 69.4% were FOG positive and were sort of the easier ones. And then there was the 9.1% were FOG negative and 15.2% were FOG neutral. And these were the harder ones to dissect. So a simple concept, very nice to teach your residents, and something that you can determine ahead of time. And we sort of correlated this with surgical time. regardless of how many cells were in the frontal recess. And we found that there was a good correlation between whether there was an upswing that was happening more posteriorly, whether compared to an upswing that was happening more anteriorly. So difficulty based on fog grading. So we gave it 4 different grades, and it all depended on having a positive grade and a large diameter, all the way down to a negative grade and a small diameter, which was the hardest to access. And you could just grade these quite nicely and then expect what would happen in surgery. So with that little bit of an introduction, I wanted to just present these to the panelists. So here's a patient that we saw a little while ago, a 47-year-old woman with right frontal sinus symptoms, just a chronic ache, chronic discharge from the right side. And this is the relevant coronal cuts, and I'll show you the video shortly. But you can see here that the right frontal recess is pretty narrow and is narrowed by the uncinate process as it sort of splits up and attaches to the orbit here and then to the skull base right there. And you've got this obstruction happening here with a very narrow opening. And as you go across the different cuts, you can see how narrow this is. And then I'll show you the actual video of the cuts so you can have a look and tell me. I want to first of all get Dr. Kuhn's thoughts on this scan. And here's her sagittal cuts.
Okay, Amin, can you go back a little bit?
So I know exactly where you want me to hold it to, so I'll go back. I have a, there. This is where you want me to hold it to.
That'll do well.
Okay. So can you give me your thoughts, or give us your thoughts?
Can you see my cursor on the screen?
No,
Probably
but I can
not.
move my cursor where you want me to move.
There, right there. Well, that's obviously the roof of what we would normally call an Agger cell. And right above it, there's another lamella of bone right there, right there. So I think you could conceivably balloon that looking just at the sagittal, and maybe that would solve the problem. In the operating room, if you decided that's what you were going to do, you could use the balloon to guide your dissection, because one of the things that you'll eventually want is to be able to separate those 2 lamellae and take the Agger posterior wall right up to the what we're now getting ready to call the superior nasal spine. We used to call it the anterior buttress of the internal frontal ostium, and then probably take out the other lamella to skull base here, and then you just have to see endoscopically when you're in there where the dissection was taking you.
Excellent. So in Canada and in a lot of the other parts of the world, balloons are expensive and not available. And
Yes.
That's the situation here, where we actually, balloons are actually not available here because they're not, the companies just don't come up here and they're not approved. But this would be an ideal balloon case because it's a single sinus and has the 2 lamella where you could go in and really just push the lamella out of the way and get this to work. And the other thing you notice is that it's quite a wide diameter and that the upswing of the skull base is more anterior.
It's very far anterior.
Around that. Yeah. So this case, we dealt with by just doing a bulla intact technique and just removing this and opening it up, and it worked out great. So that was that. So
how about Dr. Citardi and Dr. Cuilty-Siller? What do they have to say about it?
So go ahead, Martin. What are your?
Well, I mean, I think the anatomy just tells you what you need to do. You can see the individual lamella, and then with through cutting giraffe forceps, you just follow them up. We would use navigation, and that would guide us as well. And then a comment about the balloons. I'm in Texas. Balloons are common, but I wouldn't I usually don't do it for something like this. I think it's difficult to pass. And then when you're done, it's really difficult to assess that person over the long run because you can't really see everything visually with the scope in the office later. So I would be inclined to do it in the operating room, do it once and be done.
Interesting. I agree with you, Martin. I think, I mean, we don't have balloons, so we always do it in this kind of case in the operating room. But I know in the US, a lot of people would use balloons for.
How about Carlos?
Carlos, comments? Nice to see you, Carlos.
Where are you, Carlos?
Oh, you're muted.
Carlos, can you hear us? No.
Well, Martin, I agree with you as well.
All right, so I'm going to show you another case. So this is a very interesting case. This is a 51-year-old male who comes in with very severe symptoms with a SNOT score of 91. Very different case than the last one. Has had one previous surgery about 10 years ago in a different country. And this is how he presents. This is his sagittal cuts. And these are his coronal cuts. You can see the amount of osteoneogenesis here. I'm just going to get you to watch these. And particularly this last coronal cut, and you can see how tight this area is. That gives you access to the frontal recess on the left side. And then I have his coronal and sagittal videos.
All I can say is I'm glad you have such easy cases.
And I'll show you his sagittal now.
So, Amin, while you're showing us these, what's his underlying diagnosis?
He has very bad, so he's actually a healthy 51-year-old, has no other symptoms, mild asthma, and has had chronic sinusitis for years. Is not aspirin sensitive. Has actually doesn't have classic polyps. Has sort of got edema, as you can see from this scan, and just has a lot of facial pain, postnasal drainage, purulence dripping out of his sinuses, headaches. So having seen these, I'd love to hear all of your comments on the panel.
Well, my next question is, what do your culture results show?
He grew staph, and I think he also grew E. coli. If I'm not mistaken.
What's Staph aureus?
Coag-negative staph. No, it wasn't MRSA. It was coag-negative staph, and E. coli.
Have you operated on him?
No, well, I have now.
Did you by any chance ask for a tissue eosinophil count?
Yes, we always do.
And what did you get?
It was not high.
What is not high?
It was not high, and his serum eosinophil count was not high either. And he had a lot of osteoneogenesis in surgery. Like you can see that bone. I had a very hard time getting through most of that bone.
He also has something at the floor of the right maxillary sinus as well, I think.
This thing right there.
Yeah.
Yeah.
Right where?
It's like a dental, like a molar cyst almost in the.
All I can see is a white bar across the bottom.
So
it's right there.
Right there.
Oh, I see. You mean a defect in the wall? Or
it's like a little, it almost looks like a dentigerous cyst.
Yeah.
So my questions to the panel are, would you put a drill in this man?
Oh, no.
And if not, is this case amenable to an endoscopic approach? I'll go back to the pictures. Because he was very, very difficult case. So let's start with Martin.
So, I mean, in general, I think that the drill works the least well when you need it the most. So you would think in a case like this, where it's sort of a small space, a lot of reactive new bone formation, you drill away the bad bone, and then, voila, you've got the problem fixed. And in practice, it does not work like that.
Amen.
So the only caveat would be is, so sometimes if you're kind of high up and you want to not do a formal frontal sinus drill out, but you want to knock away a little piece of bone and widen it at the frontal sinus floor, but leave everything else intact, you may be able to do something like that. But I couldn't make that. I mean, I very rarely do that, but sometimes it's an option. If the piece of bone is just too thick and it's breaking the giraffe forceps, you need to mobilize it somehow. You can drill away one fragment without destroying the frontal recess.
Can we look right there at the at the left ethmoid?
Here.
What is that bone coming down from superiorly right next to the middle turbinate? Is that the bulla?
I think it's remnant bulla. Yes.
I think.
Or it could be remnant uncinate. It's hard to say for sure.
Tell me about this coagulation negative staph. Was that a heavy growth?
Yes, heavy growth.
So do you have all sinuses involved? That's what this sort of looks like.
Yes.
One thing that occurs to me that you could do would be to plan to do this in stages. And what I mean by that is that you could go in with through cutting punches and take out all of the bone that we see in the ethmoids. You could open your maxillary sinuses, you could irrigate the heck out of them. If the sphenoid's involved, you could try to do a sphenoidotomy and clean out the sphenoid sinus. And then let's go back and look at the frontal recess. The frontal sinuses don't appear to be large.
No, they're not.
Okay,
Well,
hold
this
on.
one is.
Oh, there, I see now. Okay,
The right
go back
one is.
go back 2 cuts posteriorly. Whoa. Come forward 1 cut. There. And 1 more. Wait a minute. What's forward from that? Anterior.
It's almost obliterated, self-obliterated.
There, right there. So you have what looks like an interfrontal sinus septal cell. You've got a Y-shaped top to the septum, creating a floor to that interfrontal septal cell space. And then there's a rounded bulge from the left going up in there.
Mm-hmm.
That. So what you might, to deal with that, what you might consider doing is go across the septum below that V-shaped thing and use punches to punch your way up into that interfrontal sinus septal cell. And you could conceivably do a version of a modified Lothrop right up there with punches. I could see a vertical partition coming down from the left frontal sinus, join this structure, one coming down to the center, a loop coming over from the left, from the patient's right, and another partition going up to the skull base from that floor of the interfrontal sinus septal area. If you could take that out with punches and open it up and irrigate it, you might solve a superior drainage problem. Now let's go a cut or 2 posterior to see how we would get to the left frontal sinus. Boy, that's 1 more. It's coming anterior now. One more cut. Yeah, I don't see an easy way into that left frontal sinus.
I think that's sort of the point I was trying to make. That piece
Yes.
of bone is so thick,
Yes,
you can't come through it with a cutting giraffe. That
right.
just focusing the drill right there and trying to get through it that way. But you've got to be spot on in terms of your localization with the drill, because you're a millimeter or two off and you're going to be either in the brain or the eye.
Yeah, there, a frontal recess punch would break up in there, you're right. There's some other side biting punches that might reach it, but that would be a real stretch.
So everybody agrees that this is something that needs to be done with through-cut punches in a very meticulous manner. And Martin says that you could potentially use, in some spots, a very fine, maybe diamond burr to remove some of those heavy edges and then continue with punches.
Right.
Martin,
And
am I right?
always a diamond in my hands.
Yeah. Carlos,
I'm-
any other thoughts from your?
I'm just skeptical that you could get it all done in one sitting. So I might try to get the stuff that I can take care of first, done first, and continue treating with antibiotics, get the patient healed, and then go back and have another go at the stuff superiorly.
I think that's a great plan.
So what did you do, Amin?
Carlos, do you have any thoughts before I tell you what I did?
Thank you for the invitation.
Carlos.
How are you?
Hello,
Dr. Kuhn?
hello.
Good to see you. Good to see all of you.
¿Cómo está, mi amigo?
Doing quite well. Doing good.
You look like it. You look great.
Thank you. Thank you very much. Well, this is a tough case. I think that Dr. Kuhn said try to do it in steps. I will go to both maxillary sinus and do a wide antrostomy and see how the patient does. Because even if the maxillary sinus that looks with less bony reaction than in the frontal recess, if it doesn't go well after surgery, oh well, yeah, it's done. So the prognosis is not that good. To me, it's more like a medical treatment rather than surgical treatment. I wouldn't expect good results after surgery, and I think the risk is high. That's what I will do. Maybe to go and look for biopsies and cultures everywhere in different sinuses, but try to remove that bony. I will go with the through cutting forceps.
Well, good thought. I think medical management plays a big part in a patient like this. So right here, Martin, this area here was solid, hard, rock-like bone. And I did use a diamond burr to remove all of this. This is posteriorly. Got down to the lamina papyracea. There was disease in here. And then actually managed to get into a good spot right here. And that was the key. And once I got into that spot, I could come forward and slide in behind into this space, which was leading me into the frontal recess. And the hardest bit was right here, but it's attached to the skull base. And it was just solid bone. And there was no way to get through it except to use a diamond burr. And very slowly got into this space. And actually, quite impressively, I was happy that I actually got into this space. Opened this further with, with both drills and punches. Managed to preserve a lot of the mucous membrane and stent it. And so that frontal recess opened, almost the same thing on this side, and then used punches to remove all of this and create a common cavity in the middle. And then left him on pre-op and post-op antibiotics. He's about 3 months out, stents are in position, he's healing well. I've got him rinsing with budesonide and topical antibiotics, and his symptoms are significantly better at about 3 months post-op. I have already told him that we may need to go back depending on how much he scars. I have not addressed the whatever's going on in his right maxillary sinus with that cystic lesion. I've got him to see one of my dental surgeons to see what they think. And they're thinking that it's most likely a cyst above the molar, and it may be a benign cyst. So for now, we're not going to address that until we get the sinuses under control.
And then what did you do with the middle turbinates? Seems that they're fairly osteogenic.
Yes, so I actually had to resect this part right here.
That's what I thought.
And had to resect this part right here. But when I go to the frontal, I essentially did a draft 2B kind of approach at the top, and had to remove all this osteoneogenic bone because it was just solid, and there was no way to do the surgery without removing them.
Right. And then have you been able to rescan him yet?
No, not yet. He is about 3 months post-op now, and he's doing well. I'm going to wait about another 2 or 3 months before I rescan him, probably 6 months post-op before I rescan him. And I'll send you the pictures when I get them.
Okay. And you were not able to get to the maxillary sinuses this time?
No. I did the maxillaries, I did the sphenoids, I did everything.
Oh, okay, good.
Yeah, I managed to. Well, maxillaries, I just did large introstomies, and got everything opened up nicely. They were not hard to do. The maxillaries were not hard to do. I haven't scanned the back part of this, shown you the back part of his sinuses, but I thought we were just discussing the frontals. But I did everything. I did the ethmoids, got in the sphenoids. Took about 4 hours to do the case, but managed to get everything done.
Another observation I would make is that we've been, as you know, a significant proponent of paying attention to coagulase-negative staph for a long time. And I'm thinking about the fact that it can induce superantigen.
Mm-hmm.
And you might go back and take a look at what the tissue eosinophil count was, unless it's absolutely at the bottom. It may be a sleeping indicator that you've got some problem with superantigen stimulating the production of eosinophilic inflammation.
Yeah. So when we ask for tissue eosinophilia, I usually ask them to record anything that's more than 10 for high power field. And if it's less than 10, then I don't count it as significant. What are your thoughts about that?
Well, that's a project I never got finished with. But in typing or staging my AFS/ECRS patients, some of them would have 5 out of 5 criteria. Others would have 2 out of 5 criteria. And the eosinophils, of course, were the primary constant criteria. But the ones that had 2 out of 5 had far lower tissue eosinophil counts than the ones that had 4 out of 5, 3, 4, and 5 out of 5. So a tissue eosinophil count that's just below 10 could conceivably in the long run be important. You might just go back and find out what that number was, and the next time if you have to go back and operate on again, or if the patient gets well, get a piece of tissue in the office, or if the patient gets dramatically worse, get a piece of tissue and check the eosinophil counts on them and get them to give you hard numbers instead of just categories. You just look and see if you see some fluctuation in the tissue eosinophil count depending on how the patient's doing.
And what would you then treat the patient if the
Well,
eosinophil count was high?
if I thought that there was even mild eosinophilic inflammation, I would be including steroids, which you're doing. you're doing the budesonide irrigation.
Yeah.
But then you know why you're doing it rather than thinking you need to do it.
Yeah. So I did also put him on, of course, on oral steroids pre and post-op, and
I
tapered
think
him
that
off.
was smart. I think that was very wise.
Yeah. Well, I mean, he's just very inflamed.
Amin, if you don't mind, there's one of the attendees that would like to ask you a question about this case.
Sure.
Chinju, you can go ahead. Okay, I think they're not online. Go ahead.
You know what the question was, Saad?
Nope, they would just raise their hand.
I'd like to make a comment about the cultures. So for a few years now, I've stopped doing cultures. Instead, there's a lab that we send specimens to for next generation sequencing. So it's basically direct bacterial identification. And it's just interesting what you find. The numbers and different types of bacteria are all over the place. And I'm not sure which one is quote unquote more valid, but I do get the sense I'm getting a much more complete picture of what the bacteria are. And the cost for something like that is roughly the same as a regular culture. And it takes about maybe a day or two longer to get the final result back. Just a comment.
So Martin, that's a great comment. In fact, a lot of people say that cultures are pointless in this day and age because we are now finding that the reason that people get chronic sinusitis is microbial dysbiosis and not really, one bad bug, because we have all of us have all the bugs and we just lose that balance, so to speak.
Right.
So,
and what's interesting in the patients who fail, they've and have multiple samples sent, it's very rarely the same bug repeatedly.
Really?
They're bouncing all over the place. Typically they change. I mean, we kind of compiled the data and didn't know what to do with it, how to report it, because there's no you can't report 100 specimens with no pattern, because there's literally no pattern.
Yeah. Agree. Anyway,
can I make you a question about this patient? Do you use nebulizations with budesonide instead of not instead of irrigations, also irrigations, but nebulizations, because that's the only way you can reach the roof of the nose with the nebulizations. And also, it seems to me this is a case like this is a local manifestation of a chronic inflammatory disease. So it's more an inflammatory than infectious disease. Did you go and study that patient trying to look for some protein that is the trigger mechanism for the inflammation, instead of the classic treatment of using systemic and local steroids?
Yeah, great questions, Carlos. I don't know if I know the answers to your questions, and if there is something strange going on with this patient. My feeling was that a lot of his inflammation and chronic infection was secondary to simple obstruction, and that if I could fix the drainage pathways in the anatomy and allow those sinuses a chance to aerate and reduce the inflammation, who knows how well this poor man would do, right? With a SNOT score of 91. I couldn't find anything wrong on his blood work to indicate that there was something systemic going on, but there might be. He has felt like multiple times better since his sinuses have been open and draining. I did manage to stent all of the sinuses. So I'm just hoping that now that there's drainage, there's aeration, there's anti-inflammatories going up there. Your question about using some sort of an aerosolization to get the steroids up to the top, I always use an MAD syringe, and I get the patients to lay, with their head hanging over the edge of the bed. And he's doing that every night to put the budesonide directly up into the frontal recess. I find that very, very useful, and I've published on it several times. I think just doing a rinse with your head forward with budesonide is just not going to take the medication higher up. So I completely take your point on that, and I agree with you 100% on that point of view.
Thank you, Amin. I think we're a little bit over time, and we enjoyed really the discussions. Do you want to conclude with that?
So that's my conclusion. That's right from Dr. Kuhn. He always taught me to preserve mucosa. And I think the key about doing the frontal recess, any sort of justice is not to destroy all that mucous membrane in the frontal recess. Anatomy, as we just learned in the last hour and a half, is extremely important to know. And the concepts, the new concepts that you've introduced us to, Dr. Kuhn, are excellent and something to think about, and something that I will discuss with my trainees. And I look forward to reading more of your publications on that. And of course, all the instrumentation and all the training you can get is so important and essential for a successful outcome. So Saad, thank you for inviting us. It's been a phenomenal couple of hours. We've really enjoyed it. And we hope to invite you all to Vancouver to enjoy IFOS, hopefully, fingers crossed, in a year or so. We're not doing as well as the rest of you in the US in terms of COVID, and hopefully we'll catch up by then. So thank you for having us, Saad.
Thank you, Amin. I apologize about, there are a few small little questions. We could probably just go over them quickly just before we conclude, if you don't mind, Amin. Just about the frontal sinus stent, do you use sutures sometimes, Dr. Kuhn, just to actually leave with the stent itself and remove it later on, just to prevent migration? Dr. Kuhn?
Oh, I'm sorry. I thought you were asking Dr. Javer.
No, about the stents you mentioned.
Yes.
No,
I haven't used sutures. Sometimes I make the stents longer if I'm a little bit concerned about them migrating superiorly. But for the most part, they just hang there very nicely.
Perfect. Dr. Citardi, would you use, I know that you're a big proponent of image guidance, and would you use image guidance in all cases?
I mean, effectively, that's where I'm at. I mean, certainly any frontal case, we're using navigation on all of them. And then when I say use, it's on and operational, but then the degree of use will vary. Because, depending on what the anatomy is, what the scenario is, the degree in which you need it will vary from case to case. But we basically are using it all the time now. And I'm using it a bit differently now than I was a few years ago, because the technology has shifted, over the past 3 years or so.
Agree. Dr. Siller, do you have any other, or Dr. Javer? Go ahead.
So Saad, my only comment about the image guidance, I mean, my fellows and I discuss it all the time. And one of the things that I think you and I have discussed is image guidance should not be relied upon. It's there as a tool. It's there to have the scans in front of you so you can scroll through them. But really your ultimate image guidance system is up here in your brain. And if you analyze those CT scans really carefully and you have it in front of you so you can review them, I think that's really what image guidance helps you with. I mean, it can be off, and you can't rely on it. And quite often it can be off. And so I think you really have to be careful. And if you analyze the CT scan well and have the images there for you to review during the surgery, in my opinion, that's the main reason why you use the guidance system, so that you can review the scans easily when you need to review them, not to rely on it.
I totally agree. And you actually most of the time use it just to remember the CT sometimes during the surgery itself.
Yeah.
And Dr. Siller, do you have any other thoughts about image guidance?
Well, I use it in a regular basis in all frontal cases. I've been doing a lot of school-based cases. I use it also in regular basis in school-based, and in anterior and posterior myodectomy, I don't use it in I will say in maybe about 20% of all my cases.
Perfect, thank you. The last question would be toward Dr. Kuhn. Widening the frontal sinus ostium itself anteromedially versus just removing the ethmoidal cells, meaning that one of the participants, Dr. Abdez Rashid, he's from Saudi Arabia, a good colleague, wanted to have your thoughts about actually removing some of the buttress anteriorly and anteromedially versus just removing the ethmoidal cells. When do you decide to do that?
I have to think about my answer to that. I essentially, in the only time I would ever remove bone of the basic perimeter of the frontal opening is if I was doing an intranasal modified Lothar. And the reason is if you start removing bone, then the bone and the mucosa have to heal, and there's an opportunity for osteoneogenesis to occur at that point. So my basic feeling for me and my patients has been to remove the obstructing elements and leave the frontal opening as normal as I can leave it, instead of trying to make it bigger. But that's the general thing. I'm not sure how I would answer it if it was a tiny opening, but it's rare that I ran across a tiny, tiny opening that I felt needed to be bigger. I think I'm more interested in restoring the mucociliary clearance and letting the edema go down and the thing heal before I start doing anything medially.
That's perfect. Thank you, Dr. Kuhn. And I'd like to thank everyone, all the attendees, the panelists, Dr. Citardi, Dr. Siller, Dr. Javer, especially Dr. Kuhn. A great event, and we pretty much summarized everything in endoscopic frontal sinus surgery in one lecture. I'd like to thank you again, Dr. Kuhn, and we'll hopefully have another one at some point later on.
My pleasure, Dr. Alsaleh. I just had one more thought about that last question.
Oh, sure.
I was trying to picture in my mind what someone might feel like they needed to do. If you are trying to expand the frontal opening medially and you felt that you had to do that, then you could try applying the same technique that you would for a frontal sinus rescue procedure, meaning that you would dissect the sinus mucosal flap farther up into the sinus, then resect the bone with a mushroom punch and lay the flap around the corner of that cut bone. That might work well.
So sort of a reverse frontal sinus rescue.
Well, it would be, instead of just resecting the middle turbinate to the skull base,
yeah,
you'd follow that, but you'd also elevate the flap into the sinus so you could resect a little of the medial floor of the sinus and then lay the flap back across that cut bone.
That's perfect. Well, thank you again for attending, and we'll hopefully have you again sometime in the near future. I would like to conclude the meeting.
It's been a great honor. Thank you very much.
Thank you, sir. Great honor.
Thank you. Have a good day.
You too.
Martin, nice to be with you.
Yeah, good seeing you again.
Yeah,
Good to
glad
see
you're
you.
still preaching the same word.
Oh, for sure.
You
Have a good night.
too.
Bye-bye.
Bye-bye.